screen and
he's
typing.
Looking more at the computer than he's looking at me. I don't know that he heard a word I said.
So I've practiced in both scenarios. I like the old-fashioned way more, but of course that's because I did it that way most of my career. Yeah, I learned how to use the EHR, but certainly, I think it's good for keeping track of things and for organizing things, but patients don't really like it a lot in many cases because of the hands-on care is not there anymore. People are more focused on clicking on the keyboard instead of examining the patient and talking to the patient, which is what they want.
I think you've elucidated one fear people have when they go to the hospital, is that nobody's going to listen to them, nobody's going to look at them. We talked about folks being strangers. I mean, your body cavity might get invaded while you're in the hospital. Everybody remembers that old saying, there's no body cavity that can't be reached with a good strong arm and an 18-gauge needle. I personally fear infection when you go to the hospital. That's where the real drug-resistant germs are, the bad things that can give you diarrhea that can kill you and can repeatedly give it to you, the wound infections, all the really nasty stuff. Back in the day when my kids were born, you may remember there was a big political movement to allow women to stay longer in the hospital after they delivered. They were talking about drive-by deliveries, that HMOs were throwing moms out of the hospitals really early with newborns. You know, I don't think we ever stayed 24 hours in the hospital with any of our kids. We wanted to get out of Dodge because we knew the hospital was the one place in town my kids could catch something that they couldn't catch anywhere else. So I have a fear of infection.
It can be a dangerous environment,
And I think that's a reasonable fear. So what I'd really like to have you lay out for our listeners, what's a reasonable fear when you go to the hospital? And what are some unreasonable fears people might have that they ought to be reassured they're really unreasonable fears?
But I know a reasonable fear is that you might become mentally incompetent while you're in the hospital. If you haven't made prior arrangements for power of attorney, advance directives and all, there could be decisions made about your care that you don't want. Of course, a reasonable fear, since you are likely sick when you go in, you could die. People really worry a lot about the cost. Like, I know I've got insurance or Medicare, but how much is this going to cost me? I know a big reasonable fear is the fear of patient mix-ups, drawing lab work or doing radiographic.
Now, is that a reasonable fear these days, or have most hospitals put in place such stringent double-checking that those things have become really uncommon?
I think now it's unreasonable because it's happening so much less now, though it still does happen, but there's so much.
Because I was impressed. Last time I was in the emergency room was a few years ago. I immediately got a barcode, and that barcode was matched to everything that I was given and administered, and every time a nurse pushed a drug, there was another nurse in there to scan the barcode, to look at it, to agree I was the right patient, it was the right drug, and the right dose at the right time. Hard to make a mistake unless you're really rushed and you're not paying any attention, which I guess happens sometimes.
It's a very rare occurrence now, but with the barcodes and all the double and triple checking, and it's for surgical patients, they've got about 10 people who check you out to make sure the right leg is being operated on now. So things have changed a lot in that area. So I think it's becoming a more unreasonable fear, but I still think about it. But when I'm in the hospital, I make sure that they're checking everything 2 and 3 times.
I agree. I like when they're circling the knee with the indelible marker, and it's the knee that hurts, that they're going after. But you mentioned something I think is really important that I want to come back to, and that's a reasonable fear that you haven't gotten your affairs in order, and suddenly maybe you become aphasic. Maybe you become intubated on a ventilator. Maybe you have head problems in your brain and you can't speak. You can't tell people what you want. I think you said it very kindly that their care may go in a direction they didn't desire. I think it's a lot more brutal, and I think we probably have a separate show on it, but maybe you could just tell us a few minutes. What's the default? Let's say I'm 86 years old. And I'm a frail old guy. I've got a few chronic diseases, nothing fatal, but I'm a weak 86-year-old man, and I end up in the hospital for some reason. I have not expressed my interest. I have a minor stroke. I can't speak. Things go south in terms of infection and complications. How's this going to turn out for me? Am I going to die a nice, peaceful death?
Probably not, because unless you've signed all the proper documents and appointed someone in your family who shares your beliefs to make your medical decisions, the default care will be to do everything pretty much on you until the system plays itself out. Certainly, ethics committees might get consulted later to look at you and to discuss with your family members to try to make decisions. But when nothing is formalized legally, I've noticed that family members, a lot of them mean good, but they're afraid to make decisions, even in elderly people who are terminal. No one wants to make decisions, so that's a very big fear, going into the hospital not having everything in order.
And
what
then
that
means,
pretty much,
so folks are aware, what that means, and correct me if I'm wrong on any of this, Dennis, it means probably being in an ICU, probably having a breathing tube, probably being tube fed, probably having multiple large IVs, some of them put in your chest or neck, probably having a catheter, and probably having more misery, pain, and suffering than people who aren't in that situation can possibly appreciate.
That's very accurate.
and the terminal event, and correct me if you've never seen this, but the terminal event is generally a failed advanced cardiac life support code with shocking CPR. And in an 86-year-old man, there's a good chance that the person who's doing the CPR is going to feel ribs breaking underneath their hands while they do it.
I've seen it many times in my career, and it's a very tough thing to deal with. And
that's the way people die. They die all banged up and bruised, and their bodies beaten at the very last 6 minutes of their life with their rib cage shattered.
Yeah, which is not the way really any 86-year-old person should.
I'm sorry that I'm so graphic. I do want to get a palliative care doctor on the show and talk about this issue in all its importance, but I knew as a hospitalist there's no way you could possibly have avoided that issue, and you brought it up. So I want to close out here, Dennis. If I'm going to the hospital, or my dad is going to the hospital, God rest his soul, if he went to the hospital, it would be unusual, but if somebody I love goes to the hospital, or I'm going to the hospital, what sort of advice would you have for them? What should they do? What should they anticipate? Maybe what should they not do?
First of all, I would make sure that I've got the advanced directives and medical power of attorney for healthcare issues and all. I would make sure I've got all that in order so that someone in my family who I trust will be making decisions for me, and I'll have a lot of my decisions already made on that form. It'll specify what to do and what not to do. I would also, everybody should really bring a list of their current medications and accurate doses and allergies and names of your treating physicians and major diagnoses, because a lot of people show up without that and they don't know the answers to those questions, and then you're at the mercy of what's in the electronic record. Suppose there are mistakes in there or inaccuracies. The nurses need that information to match it up to what they've got in the system.
We used to tell people, just get a big shopping bag and throw a bottle of every medicine you're on in there, and bring in a bag of bottles so we can sort it out if you can.
Bring in the bottles, or have an accurate list. Some folks type it up really nice and bring in a sheet, but it does help out a lot because I've found a lot of mistakes when I match things up, so it's good to have that. And I also would recommend that when you're in the hospital, when someone comes to do a procedure on you or draw a lab or get an x-ray or whatever, make sure they check your ID bracelet. They should. If they don't, you tell them to. Also, a lot of older people particularly go into the hospital and then they're very lonely because no one comes to visit them. So if you know you're going in advance, arrange for family and friends to come and visit you to cheer you up so you can get some contact with the outside world and not be so isolated. Another thing I might do is I would make sure that if a hospitalist is admitting you, make sure that he is told to contact your primary care physician to let him know that you're in the hospital, because sometimes the primary care doc doesn't know, and he gets upset about it. And a lot of times, if you let them know, they'll come and visit the patient on a social basis.
And they may have some information that otherwise got lost during the admission process, too.
Exactly, yeah. In the transition, you do lose. There's a big drop-off in information. You lose a lot of info when you transition from one care area to another. So yeah, it's good. So it's good to let your PCP know. And one more thing too is when someone comes in and starts to examine you and touch you and then look at you.
Oh, I hope you're going to say what I'm going to say, and that is make sure they wash their hands before they do it.
Yeah, wash their hands when they come into the room and wear gloves. Fresh gloves should be put on. If they don't do that, I would not let them touch you because they're coming out of another room. There might have been C. diff colitis in that room or MRSA infection or Lord knows what. So make sure that there's hand washing and gloves. Those are some very important, simple things that you can do to help make your
By the way, if the person's a doctor and you tell them to wash their hands, don't necessarily expect you're going to get a good response. I had that with one of my parents in the emergency room. The doctor didn't wash his hands, and I stopped him right in the middle of it. And let's just say he wasn't that pleasant about it. So, but you have to. It's better to hack off a doctor who didn't bother to wash his hands than to die in a nursing home because of a drug-resistant diarrhea you caught, just to sort of frame things up. Anything else? Any last words for our listeners, Dennis?
I just think that everyone out there, be prepared when you show up at a hospital nowadays and you get admitted via the ER. Likely you're going to be cared for by a hospitalist, and I think it's overall a very good thing. It can really contribute to good health care. Certainly you're not going to have your own primary care doctor at your bedside, but I think that if everything is done the way that it should be done, your outcomes will be good. You should be able to get good quality care and possibly get out of the hospital even a little quicker than you normally would, still with a good outcome. And once again, I think it should be a positive experience for you, but certainly it's not always going to be perfect, and that's the nature of the medical world and medical business. We can't control everything that happens. So the body can do unusual things sometimes, and
well, it sure can, and doctors do unusual things sometimes, too, don't we? Well, I'm really happy you came on, chatted with us. I would like to have you back on a show when we have some other issues that require that medical expertise that an internist and a hospitalist has. Willing to come back on and chat with me some other time, Dennis?
Yeah, I think it would be a very good idea, and I think you mentioned earlier, like possibly some joint interview maybe in the future with an emergency room physician.
And we'll see if anybody expresses an interest from our listeners, but one thing that would be nice to do is a call-in show if anybody had questions for the doctor. Not medical advice. We're not going to tell you to up or down your blood pressure medicine, but if somebody doesn't understand a medical term and they want to know a little bit more about it, it's unclear to them what's going on with this disease, that's the kind of thing we could answer over the phone, couldn't we?
Oh, yeah.
That'll be two grumpy old docs when we do that. I somehow believe that whatever you're doing, these skills, they don't go away. We are doctors. We are clinicians for life, good or bad. Dennis, thanks for coming by.
Yeah, thanks a lot for having me on the program today.
Until next time, stay healthy, my friends.
Be sure and subscribe to our podcast on iTunes, and more details at grumpyolddoc.com.